Hi, we're back. It's Gerald Major from the Canadian Spondylitis Association. We're here in Vancouver for the annual CRA and AHPA scientific meeting, and it's snowing here in Vancouver, which is a rarity. So we're going to get this interview done before the city shuts down, I think. I'm pleasantly surprised or grateful to be here with Dr. Alan Lowe, a rheumatologist out here in Vancouver.
Actually, a pharmacist.
Oh, pharmacist, sorry. And so let's get you into the introductions and tell us your story and how you ended up in rheumatology.
Sure. So my background's a pharmacist. I'm a clinical associate professor at the Faculty of Pharmaceutical Sciences. I'm also a primary care pharmacist at BioPro Biologics Pharmacy. And I guess in rheumatology, osteoporosis kind of drew me to the area first. Since then, interest in rheumatoid arthritis, osteoarthritis, and the many medications now that are available in the inflammatory area. So they're very complex, they are very expensive, and being a pharmacist, there's lots of value, I guess, we can bring to the group. And that really just attracted me to be able to participate, help, and engage with patients.
So what have you been most excited about for the CRA this year?
Actually, one of the talks by Dr. Linda Lee, she presented yesterday, and she was talking about wearables and digital devices that help patients monitor and potentially bring better attention to the care and their own management. The tough part is, I think as healthcare professionals, now we have to catch up. This is a time where the patients and the people are finding ways to monitor and self-manage even ahead of how we know how to interpret some of this information. So it is getting a little bit tough out there, but I think there are research that are happening. And so particularly for me, I like technology. It's great that we can optimize these to help patients with their condition.
Yeah, I mean, that's kind of a shift that I've seen over the last couple of years since I've been introduced to this space. And from a patient association perspective, you look to patient accountability and empowerment. And I mean, I wear my watch and it keeps me accountable.
I've got my Fitbit. Yeah, it's right here.
And, it lets me know when I'm not doing well. But, I mean, it's a different rheumatology appointment for me sometimes. When I go in there, I bring my phone, and she says, how you doing? And I can show things, how many lines I have, how much activity I've been.
Yes.
So, I mean, that's a great point. You also had a talk. So maybe...
I did. I just finished one, and it was working together to reduce osteoporosis fractures and on prevention. It was a multidisciplinary kind of talk. We had rheumatologists there, nurses, physiotherapists, pharmacists, and so it's a nice collection, and finding out how we can work best together, focusing on the patient. And with a condition like osteoporosis, which is weak bones, resulting in fractures, there's just so many things involved. Been great to have a dietitian in the audience, but we didn't have a dietitian.
Right.
But it's a condition where your diet matters, the exercise matters, the drugs matter, and of course the diagnosis and initiating the treatment. So there's just so many pieces to it that also makes it a very interesting area for me to practice and work with patients on.
Mm-hmm. I mean, interesting and exciting times, right? I mean,
absolutely.
How long you been doing this, and what are you seeing lately? A lot of people see some excitement.
Well, certainly in the osteoporosis field, is that what you're referring to?
Yeah, let's go there.
So I started in that area when the first osteoporosis treatment was available, and that was dating back, I'm going to date myself here, back to 1994 was when the first therapy for preventing a fracture really came out. And since then, there's been multiple new therapies, so it's changed the landscape a lot, and it's got lots of different options available. So you probably haven't heard of very many conditions where the treatments can range from a drug that you can take once daily, once weekly, once monthly, once every 6 months, or once a year. So there's a lot of options for you.
Yeah.
They come orally as tablets. There's also subcutaneous injections, and there's also IV infusions.
Right.
On top of that, the costs range quite a bit too. So it could be a monthly cost of $10 all the way to the monthly cost of $1,000. And there is data for each of those, and patients' preferences should really be considered when deciding on which treatment to get into and start. And this usually ends up being a lifelong therapy. So you want to choose carefully with a healthcare professional guiding you.
Yeah, you're right. I mean, we spoke earlier. I'm a spondyloarthritis patient with lots of comorbidities, osteoporosis being one. And as soon as I walked in the room, you grilled me on what medications, so that's fantastic. I love hearing about, twice now I've heard today about osteoporosis, so I'm glad to hear that.
I'm glad there's attention to it, because there is a care gap out there that I'd like to, I guess, bring attention to, and that is people who have had a fracture don't always get treatment to prevent the next fracture. Right. So they get good treatment for the surgery, potentially for a hip fracture, get good treatment to deal with the pain, get rehab, get physio.
Right.
Once people get back to functioning, I don't know what happens. We forget that we've got to prevent the next fracture.
Yeah, it doesn't make sense to do it again.
No, it doesn't. And, I think we have to use this term more, and we call it a bone attack now, because we know that people after a heart attack, you don't leave the hospital with without the list of drugs that every heart attack person walks out with. People who have had a bone attack, a fracture, don't always get that follow-up and treatment.
These are also important, and sometimes arthritis gets a backseat to things like cancer and heart and stuff like that. And it's nice to hear the analogy like that, used like that, because it's very important. I mean, fractures in elderly can lead
They're devastating. It can lead to death. There's actually a pretty high percentage rate in the elderly. It leads to long-term care for a lot of individuals. So the majority after hip fracture, that's what causes them to end up in a long-term care facility. And the rest of the 10 to 20% end up with some sort of variable function that is certainly less than before the fracture. But it's a devastating condition to have, for sure.
Just before we reach out to the audience for questions, so the theme this year is precision medicine. So we've heard from rheumatologists, we've heard from allied health. Let's hear from the pharmacy perspective. What are your thoughts on personalized medicine and precision?
There's a few ways to approach personalized medicine. It could be individualizing therapy to a particular patient. As I was saying, there's so many options for osteoporosis that talking with the patient, you can help identify which particular drug and administration is perfect for them. Maybe not everybody wants to do a subcutaneous injection. Not everyone wants to go once a year for an IV infusion and would rather go tablets. But you can have someone who doesn't want to deal with daily tablets or weekly tablets. So at least the options are there, and that could be precision medicine. Something else that we've gotten into recently is doing some genetic testing. So there's a term out there called pharmacogenomics. It's a way to check your genome and your genes to see, particularly in you, which drug you may respond to better or worse. We still need a lot more data. It's still in its infancy. But currently at the pharmacy, there are tests that you can take, like a kit called MyDNA. Okay. And you can identify within a certain group of drugs which ones are the best for you, just based on your genetic makeup. And that dictates what your enzymes for metabolism are like. And it helps to choose the drug based on your particular genetic makeup, not just because your measurements or what you tell me. It's now right into the genome.
I'm very curious about that. First, I'm hearing about it. I might be a bit out of date on that stuff, but I mean, from the average patient, can you share a success story that you've had as a result of this test? I mean, you said that you need more data, but...
Yes. So I guess there's been very few consultations. It is newly launched. We have spoken to a few patients about this, and what it helps the clinicians and I guess the patients decide on is if, let's say in an example where they have depression to be treated, there are multiple drugs to treat depression. Right. If you have certain enzymes that are more abundant because of your genetic makeup, you might need a higher dose of that particular antidepressant to work. So you have a couple of choices. You can use a higher dose of it, or switch to something else that you aren't metabolizing and getting rid of in your body very quickly, and then you can use a normal dose. The downside of a high dose is that it's going to cost more. The good thing about identifying the right drug is that one is going to be the most cost effective, and you'll know that it works, that the body isn't just getting rid of it too quickly, and that's just based on a genome test that's looking at your metabolic enzymes.
Excellent. I mean, that sounds fantastic. Mental health. Interesting you bring up mental health because, I mean, it's so much trial and error. So if this can get closer to better outcomes.
And that's where precision medicine is going.
First.
Yes, and that's where precision medicine is going. We certainly hope that we're going to get better understanding of using the biologics in rheumatology and immunology areas. These are very expensive drugs. These are drugs that range in $20,000 per year and up. And if you're not responding to it, we'd like to know ahead of time before you start taking it. And these genetic tests have that potential. We aren't quite there. The data's still building. But we can foresee a day where, after doing a genetic test, identify which of those biologics would be most effective for you and also be most cost effective. So lowest cost, best effect, least side effect. And that's going to be the goal.
Is there a way for patients to help out with any type of data collection and registries or anything like that?
I guess there are clinical trials that are continually going on. And as people are willing to sign up for those, sometimes your doctor or specialists have trials that are going on that you can ask about. Otherwise, most of the time, they are posted on the internet now when they are recruiting. Do be careful to make sure it's an authentic clinical trial, that it's sponsored by a reputable group. If it's a university, if it's a physician who's licensed, you can certainly be more comfortable. Just be a little bit wary because there's other things out there that you have to be cautious of. But in general, there are studies that are ongoing, and you'll see kits that are available to do testing. The important thing is that as you get these tests, there's going to be a request for consent to see if your data can be thrown into a big pool so that it adds to that database. And you can agree to it or not, and that's what's going to help build the repository, because it's all built on connections.
Yeah. And that's how we give back as patients, and that's how we move forward, right?
Exactly.
So, anything coming from outside?
There are more pharmacists than there are rheumatologists, so it's easier to visit a pharmacist. They're more accessible. What is the role of pharmacists in arthritis healthcare? What can a pharmacist do?
So, love that question, and there's a lot pharmacists can do. The accessibility is actually one of the important points I'd like to point out. Great that you recognize there's more pharmacists than rheumatologists that are out there. It means that you have a place that's easy access, some healthcare professional you can go to very quickly and have access and be able to ask a question. They are trained, they're licensed, they're certified, and can help with most questions, even if they aren't specifically drug-related, because the training is quite broad. There's going to be explanations of the medications so that you can understand how to use them appropriately, how to administer them, as well as the potential risks and benefits associated. As with all drugs, it's always a balance. Drugs that have an effect can potentially have an adverse effect, and it just depends on the person. So that has to balance out. Sometimes there's multiple choices that you can choose from. There's also times where if you do happen to have, let's say, an adverse effect, you'd like to know, is this one that's going to disappear over time, or this is something you've got to live with for a long term? And this is something a pharmacist could help answer. So you have access to somebody who can really answer and educate some questions, help you better self-manage, potentially help screen or identify any other drug-related issues that are going on, and either resolve them directly or maybe refer you back to your physician with a recommendation. Great thing is in school, we always teach the pharmacist that if you are referring or going to be contacting the physician, you have a recommendation ready that's individualized to that patient to provide. So, there's a problem that you find and you have an answer, but sometimes you need further communication because you don't have the full background medical history that the physician would have.
In terms of medications, is the treatment therapy similar for osteoporosis versus osteoarthritis?
Yes, that's a really good question as well. So osteoporosis is thin or weak bones that put you at high risk for fracture. Osteoarthritis is a completely different condition. I know they have similar names when you say them. So osteoarthritis is actually a degeneration in your joints. So one is weak bones leading to fracture. The other one, osteoarthritis, is pain in your joints, sometimes preventing you from having activity, and they're painful.
So that's it for everyone else there. I want to thank you so much. It was very nice getting to know you. I have a lot of respect and a lot of benefit from my community pharmacist, so thank you very much.
That's great. Thanks very much.